All right, here we are. Welcome everyone to another episode of NMA Talks. My name is Dr. Michael Knight. I'm an internal medicine and obesity medicine physician and in faculty at the George Washington University in Washington, D.C. NMA Talks is a program that's brought to you by the National Medical Association that's particularly developed for members of the general public to talk about health issues and health issues that matter. And so tonight we're excited to be here to talk about colorectal cancer awareness. It is Colorectal Cancer Awareness Month, and we have a great panel of guests that are here tonight. I particularly want to introduce Ms. Elizabeth Carter, who is here with our partner, AARP. And so I want to give Dr. Carter a few moments to make some introductory remarks.
Thank you, Dr. Knight, and thank you for having me, including me on this panel. Very happy to be here. As you mentioned, it is Colorectal Cancer Awareness Month, so this is perfect timing for this talk. And we know that colorectal cancer, although it's decreasing in the general population, the rates are increasing among younger adults. So adults under the age of 50 especially are being hit especially hard, and especially in the Black communities as well, are disproportionately affected by colorectal cancer. So I really appreciate the National Medical Association having me here tonight to talk about this important issue.
Thank you, Dr. Carter, for being with us tonight and for those great words. I want to now give an opportunity for our panelists to give a quick line of introduction. Let's start with Dr. Lanla Conteh.
Hello, everyone. Dr. Knight, thank you for hosting this. And of course, the National Medical Association, the NMA, for putting on talks like this because it's so important. My name is Lanla Conteh, and I'm an associate professor of internal medicine at Ohio State University Medical Center. I'm a board-certified gastroenterologist and transplant hepatologist, and my research interests are in liver disease, liver cancer, and access to colon cancer screening, which we'll talk about some more this evening. I'm very happy to be here. Thank you.
Thank you, and let's go to Dr. Marie Borum. Dr. Borum. I think we may be frozen, so let's come back to Dr. Borum and let's go to Dr. Mitchell. Dr. Edith Mitchell, please introduce yourself to the audience tonight.
Thank you so much, Dr. Knight, and it's a pleasure to be with this program of the National Medical Association. And thanks to Dr. Elizabeth Carter from the AARP. So it's a pleasure to be here. I'm Edith Mitchell, and I'm clinical professor of medicine and medical oncology at the Sidney Kimmel Cancer Center at Thomas Jefferson University in Philadelphia, where I am one of the associate directors of the Cancer Center, and I direct the center to eliminate cancer disparities. I'm also editor-in-chief of the Journal of the National Medical Association and a past president of the National Medical Association. So I am very privileged to be here tonight, and I will speak on the treatment of colon and rectal cancer in relationship to precision medicine. And Dr. Carter, I will be talking about some of what we know about the precision medicine and the treatment of young individuals with colon and rectal cancer.
Thank you so much, Dr. Mitchell. I know with Dr. Borum, we're going to try to get her back on the program, but let's jump right into this. You know, it's Colorectal Cancer Awareness Month. I'm going to start with you, Dr. Conteh. What is colorectal cancer? Can you just break it down to the basics? What are we talking about?
Yeah, so colon cancer, I think everyone hears the word cancer, and obviously we all get incredibly nervous. So colon cancer specifically is a cancer that affects the large intestines, otherwise known as the colon. And essentially, for people, to explain it incredibly simply, your colon is the organ in your body that does the final part of digesting food, absorbing water, and the end of the colon is where stool comes out. So in very, very basic terms, that is what colon cancer is. And there are many risk factors for colon cancer, some of which we can get into, such as family history or things that put people at high risk, which would be important for people to be aware of. But in very, very basic terms, it is the cancer that impacts the large intestine, which is the colon.
Thank you so much, Dr. Conteh, for that explanation. You know, we did a program, the NMA Talks did a program on this last fall, when unfortunately we lost one of the great actors, Mr. Chadwick Boseman. And that really brought a lot of attention to colorectal cancer rates, particularly in the African American community. Dr. Borum, I see you have come back online with us. I'm going to have you give a quick introduction, and then I want you to tell us why colorectal cancer awareness is important for the African American community.
So thank you so much, Dr. Knight, and I thank everybody else for allowing me to be part of this really esteemed panel. So I'm Dr. Marie Borum. I'm at George Washington University. I'm the Director of Gastroenterology and Liver Disease there. And part of my clinical and research interests at GW have been in colon cancer with a focus on health disparities and also on women. Colon cancer for me is something that I've been looking at ever since I was a young physician in training, working in the laboratory, looking at colon cancer in malls, and then translating that to my practice, to my clinical research work. Colon cancer for me is so important because as I know you have all heard and everybody knows, it is a lethal cancer worldwide, and it is one of the leading causes of death.
Dr. Borum, I think we're losing you.
In the United States.
Okay.
And African Americans.
All right, Dr. Borum, we're going to bring you back in a second. Let's go back to Dr. Conteh. So what Dr. Borum was trying to outline was why colorectal cancer rates are affecting the African American community. Can you talk to us a little bit more about that?
Absolutely. So
rates of advanced cancer.
So moments like this are so
and
important.
It is so
to really raise awareness to colorectal cancer. And Dr. Knight, you were asking initially why colorectal cancer awareness is so important. We all need to be made aware of this disease. Unfortunately, especially in the African American community, so many people don't know about it, know how to get screened for it. So even though we highlight as Colon Cancer Awareness Month, really we should be talking about this 12 months out of the year. When we talk specifically about the African American community in colon cancer, we know that rates within the African American community are higher for colon cancer. And there are many different reasons for that. One of those reasons is that people simply don't know, and people are not being offered colon cancer screening in a timely manner. So potentially we may see patients present when they have symptoms of cancer as opposed to being screened, which happens when you don't have symptoms of cancer yet. And the goal is to find an illness before it becomes symptomatic, where it may be advanced. And outside of that, we also know that when we look at demographics such as age, we know that African Americans are afflicted with colon cancer at younger ages compared to other populations and other ethnicities. So for those reasons, that's why it's so important to focus on colon cancer across every community and demographic, but especially so within the African community because of the age at which patients are getting impacted being so much younger than others.
Thank you so much, Dr. Conteh. When we think about colorectal cancer, the next question that comes to someone's mind is, well, how do I know if I have it, right? What are the symptoms of colorectal cancer? When should people start getting screened? Dr. Mitchell, I know you do more on the treatment side, but as a patient who wants to be very proactive, they come to your office, say, Dr. Mitchell, I'm worried about colorectal cancer. What do you tell them?
That we need to realize is that for colorectal cancer, once people develop symptoms, screening is out of the question. What screening means is that the individual has no symptoms, is doing well, and is having no problems. And then based on their age and other characteristics, including the family history, we ask the gastroenterologist to test. And there are multiple ways of testing. Everybody knows about and hears about colonoscopy, but there are other ways that screening can take place. Some, for example, use the FIT test, and it's appropriate for some individuals, not for everyone. And if the FIT test is positive, this is a stool-based test. So therefore, for screening, this stool-based test may be good for some individuals and not for others. And your doctor can tell you, based on a lot of information, whether a stool-based test would be okay, or if you need to go directly to colonoscopy. However, if the stool-based test is positive, then one will need to undergo a colonoscopy for diagnosis. So screening is available for individuals who have no symptoms, and they should talk it over with their doctor when to begin screening. But for most individuals, the age of 45 is the age to begin screening. Some people, we begin screening prior to that, and that's based on a number of characteristics of the individual. So they should discuss it with their doctor. Once somebody has symptoms, blood in the stool, abdominal pain, mass in the abdomen, or other factors that actually point to a colon cancer, that's not screening, that's diagnostic testing. And individuals would need to undergo diagnostic testing based on their doctor's recommendations and the consultants.
Mm-hmm. Mm-hmm.
So by the time there are symptoms of colon cancer, it's too late for screening. And that is more indicative, those symptoms are more indicative of actual colon cancer disease. And that, unfortunately, is frequently related to late stage or advanced disease.
Mm-hmm. Dr. Carter, I want to bring you in here, just talking generally, when we hear people talk about colorectal cancer, talk about colon cancer screening, we know recommendations have been changing. What have you heard from people when they think about, when to get screened? Who do they talk to?
Well, it's very important that patients have conversations with their physicians where they bring up possible family history, risk factors that they may encounter. And we're finding that, as Dr. Mitchell said, screening is very important. And the American Cancer Society is suggesting that people start screening for colorectal cancer at age 45. And so the age is coming down, especially because we're seeing more cancers in younger and middle-aged adults. And nearly 1/3 of people over 50 have not been screened, and nearly a half of adults who are 50 to 55 have not been screened. So it's really important because, as Dr. Mitchell said, once symptoms occur, it's no longer screening, it's more diagnostic. So it's very important to get screened even when no symptoms are present.
Thank you, Dr. Carter. Dr. Borum, welcome back. Let's bring you in right here, because what we just heard from Dr. Carter is that there are a number of individuals who should be getting screened but are not getting screened. Why is that happening?
There are so many factors that contribute to the whole screening process, as we all know. One of the factors, and I think you can divide them into categories. One is the person, the individual, the patient who doesn't know about screening recommendations, who doesn't have access to screening options, or is nervous about getting screening. Mm-hmm. The second factor sometimes are physician or clinician-based factors, where that is just inadvertently not included as part of the recommendations as they're doing health maintenance. And then there are also factors that are related to organizational or logistical barriers, where someone wants to get screened, they've advised to get screened, they know they should be screened, but it's just difficult to get all of that to work. It's difficult to get the proper transportation. It's difficult to manage some personal issues like family being taken care of while you're undergoing the process. And it's difficult even to get the laxatives that may be necessary for you to prepare. So I look at it as a three-pronged issue. One is a patient issue, one is a provider issue, and one is an organizational or logistical issue. And all of that overwhelmingly has to do sometimes with just knowledge. It's so important that we advise people regularly, and we advise people frequently, and we advise people to not only take care of themselves and their friends and their family. And we continue to recommend this type of screening when even when we think that we may have said it once, but to say it more than once.
Thank you, Dr. Borum. Dr. Conteh, what we just heard about some barriers that are in place. So let's say we have someone who is watching the program tonight and they're 45. They've never heard of colonoscopy. They may not be aware of the options. Can you take us through a little bit more specifically on what is a colonoscopy?
Absolutely. So going back to that, if this has been mentioned a few times, the one thing that we always want to relay to patients and providers alike who refer patients to us is that the most important colon cancer screening test is the one that gets completed. So the one that's easiest and most feasible for the patient to get done. The colonoscopy certainly has its challenges, but there are other tests that can be done, some of which have been mentioned already. Some as simple as Y-axial testing, and I'm sure some others that we'll talk about as well. So what a colonoscopy is specifically, it's done by an endoscopist, usually a gastroenterologist in most cases. Some surgeons do them as well. But essentially, it involves cleansing your colon. For us to be able to screen for colon cancer, what we are looking for are growths in the lining of your colon called polyps. For us to be able to see polyps, which is how most colon cancer starts, we have to be able to see the lining of your colon well. In order to do that, we need to make sure that your colon is clean, what we call prepped. The way you prep for a colonoscopy, essentially this is a two-stage process. The way we prep for a colonoscopy is drinking a solution, a fluid, to cleanse your bowels. And there are different solutions that we use, some over the counter, some a prescription that your doctor can discuss with you. So you prep for a colonoscopy usually the day before or the middle of the night before a colonoscopy to get your bowels clean and get rid of all the stool. So that's the first step. And then you come into the physician's office to get the actual procedure done. And to do a colonoscopy, oftentimes we sedate you, where we put you to sleep. It doesn't have to be completely asleep, but we give you medications to make the procedure comfortable for you. And then we go in with an instrument called a colonoscope. It's a tube that has a camera and a light at the end of it. And we work this tube around your colon, really taking a look to look for polyps or anything abnormal. Hopefully we don't find colon cancer while we do this, because hopefully this is done early enough before you ever get to that stage. But that is essentially what a colonoscopy is. And if we see anything concerning, we remove it or we take samples of it called biopsies that we can examine under the microscope to get more information. And patients go home the same day that their procedure is done.
Thank you, Dr. Conteh. And again, we want to listen to the details. For many patients, they don't know what's involved, and it could be a little bit intimidating. So I love the way that you have outlined some of the steps involved, as well as knowing that that is not the only option for colon cancer screening. So you need to talk to your healthcare provider about what's the best option for you. So let's now move forward a little bit, and we're going to bring in Dr. Mitchell here, okay? So we know that we've done the screening. I've gone to get my colonoscopy. Polyp has been noticed, or there's something that was found on the colonoscopy, and I get the call that it's colorectal cancer. Is that a death sentence, Dr. Mitchell?
Much for asking me that question, because treatments for colon and rectal cancer have improved significantly. So I'll start with surgery. The best method of taking care of patients and the initial step is evaluating for surgery. The evaluation for surgery includes a CAT scan of the chest, abdomen, and pelvis, because we want to know if there is any evidence of the cancer spreading to other organs, and whether there is any evidence of enlarged lymph nodes that might have cancer. So we do that. We also do some blood tests and look for a tumor marker in the blood. It's called CEA. So we want to know if there is any elevation of CEA, because that is a blood test that can be utilized to help us determine whether there is spread, and if there is spread to other organs, how far is that spread, and is it important? And the basic knowledge that we want to know at the end of that evaluation for surgery is, can this cancer be removed with just surgery alone? Other tests may be done, and that includes an MRI to identify the size of the tumor, whether blood vessels or other organs are involved, and therefore to determine if the tumor can be removed with surgery. For some tumors, especially those cancers in the rectum, we may add some chemotherapy and irradiation prior to the surgical procedure. If the cancer is larger and we can see it in the bowel, even if there are no metastases, we can give chemotherapy that is very targeted, and it can shrink the tumor and allow better surgical removal of that tumor. So there is a diagnostic process that the doctors will go through. It's multi specialties. So we'll have our radiology colleagues to help us with the scans that I mentioned. We'll have the surgical evaluation, as well as a radiation oncologist and a medical oncologist. And with this multidisciplinary team, which every patient should have before undergoing surgery, to define the best treatment plan for the patient. So in summary, that diagnostic and treatment plan could involve and must involve radiologists, the surgeon, the radiation oncologist, the medical oncologist, and we also include our genetic colleagues to determine if the colon cancer is related to genetics or a family disposition where there is family transfer of the genes causing colon cancer from the parent to the child. And therefore, this may be present for multi-generations before it is recognized that this is a genetic inherited cancer. So all of that is involved in order to develop a treatment plan for the patient. And colorectal cancer is not a death sentence. The overall, for patients who are surgically treated, the overall 5-year survival rate is approximately 75% and is 80% in others. It is important for us to recognize, however, that for African Americans have more aggressive tumors. They've already spread to other parts of the body at the time of diagnosis, and also more aggressive tumors. So that for African Americans overall, there's a 20% higher incidence rate, and that is 20% higher chance of developing colorectal cancer and a 40% higher chance of death from the colon cancer. Therefore, it's very important. Go to a center that offers multidisciplinary care so you can get the best treatment plan before surgery or chemotherapy. It's also important to make sure and to test for inherited genes. And you do that not after the surgery, but before the surgery is done, because the surgery may differ significantly. And then we test the tumor for various markers, and those markers should be done on the biopsy that the gastroenterologist has completed, so that we know what kind of chemotherapies and immunotherapies that tumor is likely to respond to. So there's a lot of information, all of it very good, and I encourage my patients to go onto clinical trials, because the importance of clinical trials is related to the new development, the finding of more mutations, and to know exactly what treatment this patient's tumor is likely to respond to. So I've been doing research on precision medicine and new treatments for colon and rectal cancer for about 45 years. And therefore, I've seen and I've been involved in all of these changes over the years. And yes, I have patients with metastatic colon cancer who have lived more than 20 years, and they've gone through many of these clinical trials. So even if there is evidence of metastases to the liver, to the lungs, or to other organs, patients can still expect to live a long time and to have long longevity despite having metastatic colon and rectal cancer.
Thank you, Dr. Mitchell. And that was such a comprehensive review of the treatment. So let's kind of recap of what we've covered so far tonight. We know that colorectal cancer is affecting the United States and particularly also the African American community. We know that at age 45, for individuals at average risk, they should start colorectal cancer screening. If you're unsure about your risk, this is the time to talk to your healthcare provider. We also know that there are many ways to screen for colorectal cancer, whether it is a colonoscopy or there are stool-based methods of testing and other options that may be available to you. And we have just learned from Dr. Mitchell that colorectal cancer is not a death sentence, and the treatments have become much more advanced and may include things like surgery, resection, that means removal of the cancer, as well as chemotherapy or other options. So at this point, Dr. Carter, I'm going to be going to you because we've heard all of these things, but you know what the question that comes next for patients is, well, what can I do to prevent it? You know, we talk about what may be coming. What could we do? What can patients do to prevent colon cancer?
That's a great question because prevention is the disease is really is affecting the African American community at such a high rate that prevention is really the best medicine at this point. So there are some risk factors that are such as family history that cannot be changed, but there are also modifiable risk factors, meaning a person can change their own behavior to reduce their risk of colorectal cancer. So some of those risk factors are staying at a healthy weight may help lower your risk of colorectal cancer, increasing the amount and intensity of physical activity, limiting red and processed meats. There seems to be a link between processed meats and red meats and the development of colorectal cancer. Eating more fruits and vegetables and whole grains may help lower your risk of colorectal cancer. Not drinking alcohol or reducing the amount of alcohol you drink is also something that can be done. And finally, quitting smoking may help lower your risk of colorectal cancer and also many other types of cancer as well. So that is something that these are all things within a person's own control to be done to reduce the risk of colorectal cancer.
Thank you, Dr. Carter. Dr. Conteh, I'm going to bring you in here because we've just heard a number of things that can be done to reduce the risk. One of the things that a lot of patients will say to me is, this link between red meat and colorectal cancer, can you make sense of that? Why is that linked to increased risk? Or is it? Can you break that down for our audience tonight?
That's a great question. And we know the American diet loves red meat.
Mm-hmm.
It's very, very challenging for patients. So the exact science between why that link exists is not entirely clear. But as Dr. Carter has stated, unfortunately, we've seen multiple studies that have supported that a diet that's high in red meat, that's rich in red meat, can predispose patients to colorectal cancer. Certainly, I want to take this opportunity to put a plug in for the Mediterranean diet as well, which is healthy across so many levels and so many disease states. But going back to the specific red meat issue, there's no direct factor that we can link, but we know that there's certainly an association that's been proven again and again in multiple studies. And we're not saying, I personally believe everything in life is about moderation. We are not saying to patients and to our general public, don't eat red meat at all. What we're saying is monitor the consumption of that. And if you're a big red meat eater, let's try to cut back on how much we consume because of that link and just because of red meat's impact in many other disease states as well.
Thank you, Dr. Conteh. You know, this is important, and I love when
Dr. Knight, I would like to add a little bit to what the others have said.
Sure.
If you look at information throughout the world and the World Health Organization's recommendations, it's not so much red meat as it is processed meat. Mm-hmm. And processed meat is in the same category as cigarette smoking and asbestos. So we know those cause cancer. Mm-hmm. For red meat, we don't know so much, we suspect, but it hasn't been proven in clinical trials. So that what I recommend to my patients is limit the amount of processed meat, the hot dogs, the bacon, etc. But for clear red meat alone, if you're going to consume it, remove the fat. And no, it hasn't been proven, but it is suspicious of being related to cancer. And therefore, the diet should be moderation. Mm-hmm. And like Dr. Conteh said, the Mediterranean diet, having a lot of fruits and vegetables, lot of fiber, and low amounts of red meat, low amounts, and no processed meats. And that is important. Others have recommended aspirin as a preventive strategy, and that can be effective, but no one should take aspirin until they talk with their doctors about it because of potential side effects.
So Dr. Mitchell, are you telling me that, you know, the weather is getting warm, we're ready for the cookout? Can I not have any burgers or hot dogs? Is that definitely good? So if I have one burger, am I on the road to colorectal cancer?
As I said, red meat has not been proven. Mm-hmm. So my recommendation is limit the amount. And for processed meats, hot dogs on a grill, that's equivalent to smoking. Mm-hmm. So it has definitely been associated with cancer and multiple types of cancer.
Yes, thank you, Dr. Mitchell. You know, this is so important, and sometimes it's hard to hear, but we have to realize that what we eat has a great impact on our health. And Dr. Borum, you have done, you know, extensive research in this. I know this is something that you have talked to with your patients about prevention and about nutrition. And I know because I've sent my patients to you, Dr. Borum. Can you talk to us a little bit more about that? You know, we talked about some of the damage that processed meats can do. What about the benefit that fruits, vegetables, and fiber can be for preventing colorectal cancer?
And that's exactly right. And I'm so glad that you brought that up, to Dr. Knight, because we sit here and we think about all the things we shouldn't do, we can't do, we're advised not to do. And we talk about taking away some things that have been in our diet for a long time or that are tasty to us. So the red meat, the processed meat, the grilled meats, and all of those things that can be converted to things that may increase our risk are things that we sometimes, unfortunately, do not want to take out of our diet. But there are things that have been shown by multiple studies that can actually be quite helpful. And those, of course, include just the things that you mentioned. Fresh fruits and vegetables we know are beneficial to our diet and to a number of health factors, including the potential decrease or modifying our risk factor for colon cancer. We also know that maintaining a high fiber in our diet is important. And there have been a number of speculative ideas about why that's the case, but the recommendation to make sure that we have adequate fiber, make sure that we have fruits and vegetables that are healthy for us, and also make sure that we have adequate recommended amount of calcium in our diet. This has been it has been demonstrated in some studies in humans when they look at diet. And I think that if we just do things in moderation and maintain a healthy diet that everybody on our panel has mentioned, Dr. Conteh, Dr. Mitchell, Dr. Carter, then we will be on the road to maintaining good health. The red meat is something that many people are disappointed about, but in moderation, I think that is the most important thing. But increase your fruits and vegetables, increase the fiber in your diet, and make sure you have good calcium and vitamin D.
Thank you, Dr. Borum. I love the way that you outlined that. And we want to focus on a negative, but also on the positive and what people can do to be empowered. Dr. Carter, I want to bring you in here really quickly because this is a topic that I want to switch to. Again, if you're watching and you have questions for the audience, for the speakers, please put it in the comments so we can get it into the program. Dr. Carter, and you were talking about the statistics earlier in the program, and particularly the statistic of colorectal cancer in young people. Can you take us back to those statistics so we can go to that portion of our discussion?
Certainly. As an epidemiologist, I love talking about data and numbers and statistics. But we know that about 12% of all new cancers are in people under the age of 50. And this has been on the rise for the past 9 or 10 years or so. So while colorectal cancer has been decreasing among older adults, middle-aged adults has been seeing a kind of almost a steady increase. We're not really certain why that is, but it just highlights the importance of screening. We know that if 80% of people 50 and older were screened for colorectal cancer, we could reduce the number of colorectal cancer-related deaths by over 200,000. So screening is really important, and especially in the younger population.
Thank you, Dr. Carter. Dr. Conteh, I want to bring you in here because, when we think about the younger population, we know that the recommendation is 45, unless you are high risk. But I had a patient even this week that came to me. He was 35, and he said, I'm really concerned about colorectal cancer. I've seen it in the news. I'm very worried. Can I start being screened now? How do you have that conversation? I'm sure someone listening tonight may be thinking similar things.
That's a great question for sure. And it's interesting you mentioned that because I was having the same conversation with my siblings. Certainly with Chadwick Boseman's death recently. And for many of us, I think we are starting to know younger and younger individuals who've been afflicted with this disease and who've passed away from this disease. One of my medical school classmates did, unfortunately, at a very young age recently. So to talk about the recommendations on a broader scale, the recommendation currently is to start at the age of 50. Recently, that number, as Dr. Carter mentioned earlier, was decreased to 45. For some years now, we've known that the recommendation has been to start screening African Americans actually at the age of 45 for many of the reasons that have been pointed out. So ideally, all patients across the board who are average risk should start at the age of 45. Now, insurance companies are coming around with trying to move from starting at the age of 50 and moving down to 45. So we're waiting for 100% back-in on that. But certainly when you talk about things like colonoscopy, those are not cheap at all, unfortunately. But again, goes back to reinforce some of those other forms of colon cancer screening that are available and significantly cheaper than a colonoscopy in some cases. So to your specific question about a 35-year-old, if they're average risk, it's going to be very hard, unfortunately, to say, yes, let's start screening at the age of 35. Because then when you start that, well, when do we do the next colonoscopy? Is it in 10 years when they're 45? And the more challenging issue, again, is having insurance companies pay for screening that starts at the age of 35 in a patient who is average risk. Now, certainly, as we've mentioned, there are certain disease states and family history that puts patients in what we call a higher risk category. If you have a first degree relative, multiple second degree relatives with colon cancer, and if you have certain illnesses like inflammatory bowel disease, those things certainly will push your screening calendar up below the age of 45 years. However, the current recommendation across the board for average risk patients, again, is to start at 45. So for that 35-year-old, I would do my best to reassure them to say, let's start screening you at 45. Now, certainly, if they have symptoms, if they're anemic, and you can't find a good reason, and they have something like iron deficiency anemia, if they're having any blood in their stool, if they're having severe abdominal pain, if they're having those symptoms, that should pique your interest, and that should make you go looking for something like colon cancer earlier than you should.
Thank you, Dr. Conteh, and particularly thank you for talking about some of those symptoms. As Dr. Mitchell outlined, you don't want to wait till symptoms to have investigation for screening if you're in the screening category. But if you're a younger individual and you are having, as Dr. Conteh outlined, low blood counts, or we hear people talk about anemia, low blood counts, if you are having an upset stomach that's just very strange and continues, your stool has changed, the constipation is coming that was not there before, talk to your healthcare provider. As a primary care physician, I have these conversations with my patients many times, and I'm able to identify when something, is just not right. And we want you to have a relationship with your healthcare provider that you feel that they can listen to you and you can have an honest conversation. And we know that having that patient and provider relationship is so very, very important. So as we come to the close of our program, if you have any additional questions, please put them in the chat. I'm going to go around and I want each one of our panelists to give us one take-home point. Okay, and obviously the first person I call is gonna have the benefit of being able to say whatever, and everyone else by the last person. So think about probably about four, so that by the time I get to you, you have something in your back pocket. Let's start with Dr. Carter. Dr. Carter, what is a take-home point that you want to make sure that everyone listening tonight remembers about colorectal cancer?
There's so many good ones, but I would say that about 18,000 people under the age of 50 develop colon cancer every year. And so the real take-home message, I think, is that this is affecting younger populations, and screening starting at the age of 45 is very important.
Thank you, Dr. Carter. Screening at age 45 is very, very important. Let's come back out and go to our next panelist, and that is going to be Dr. Conteh. Dr. Conteh, you're up next. What's one thing you want folks to remember when they leave tonight?
Talk to your doctor. Talk to your doctor. Advocate for yourself. Again, we've talked about colonoscopy a lot. But remember that it's not the only test that can screen for colon cancer. Again, the most effective test is the one that gets completed and the one that you as a patient can get done. So talk to your doctor about your different options, because I promise you that there are many. You just need to get one of them done.
Thank you, Dr. Conteh. Hear that? There's more than one option. So those folks who a little scary, don't know about the colonoscopy, have a conversation. Express how you're feeling to your doctor and see if there's other options for you. Dr. Borum, you're up next. What do you want our audience to remember?
Well, I certainly have to piggyback on Dr. Carter and Dr. Conteh. Colon cancer is common. Colon cancer is lethal, and colon cancer is one of the leading causes of death from cancer in the United States. So it is critical that we get screened. It's critical that we ask the questions, that we advocate for ourselves, we advocate for our friends, family, and community. It is something that we don't have to die from, and is something that we can decrease the incidence, the prevalence, and the morbidity related to this disease. It's just important to be aware, and it's important to talk about it.
Thank you, Dr. Borum. And of course, Dr. Edith Mitchell. What would you want our audience to remember tonight?
So, my colleagues have given extraordinary information. And what I want to say is, yes, do everything you can to prevent the colon cancer. And that includes screening and colonoscopy, because at colonoscopy, polyps may be removed. And these polyps, if left in place, can later develop into cancer. And remember that a polyp that is removed from the colon and rectal area will never develop into a cancer. But if a cancer is found, make sure you get all the information you can. And one of the most important things that you can get in terms of information is the genomics of the tumor. And don't be afraid of the G word. Get the genomics of the tumor, because this can help, one, determine prognosis, but more importantly, develop a treatment plan. So don't be afraid to talk about it. Let's get the information we need. Let's get the prevention aspects with diet and other parameters, best diagnostic test, and then the best treatment, and get into clinical trials.
All right. Dr. Mitchell rounded us out with her list. I'm just going to recap because that was definitely more than 4. But we have great information for you all to remember. 45, as Dr. Carter told us, at age 45, that is the recommendation for an average risk. If you're unsure of your risk, talk to your healthcare provider. And that goes to what Dr. Conteh said. Talk to your doctor about the best option for you. The best option is the one that's going to get done. Dr. Borum reminded us that colorectal cancer is common, it is lethal, and is a leading cause of death. So let's take this seriously and let's be empowered. And most definitely Dr. Mitchell, who gave us many things to remember, and most importantly, there are so many treatment options. Don't be afraid of clinical trials. Don't be afraid of the name genomics. Talk to your healthcare professional about the best option. And so we hope with that information, you'll be empowered to not only take this information for your own health, but to share this with someone. Share this video, forward it, let people know that colorectal cancer is important. And now you have been empowered with the information to keep yourself and your family and those that you love safe and knowledgeable about ways to improve their overall health. So with that, we want to thank you all for joining us tonight. We want to thank Dr. Conteh, Dr. Carter, Dr. Mitchell, and Dr. Borum, who have been an exceptional panel tonight as we talked about colorectal cancer during Colorectal Cancer Awareness. AARP, thank you for being a partner to us. And again, please share, please like. This is NMA Talks. Please look out for our future programs. And until the next time, I'm Dr. Michael Knight, thanking you for joining us. Have a good night.